Chapter 45, The Child with Respiratory Alteration continued. Sudden infant death syndrome, or SIDS, is a sudden unexplained death of an infant younger than 1 year old. The cause is unknown, occurs most frequently between 2 and 4 months of age, and more common in boys, low birth weight infants, and infants from lower socioeconomic status. Some theories on causative factors or preventative measures include infants should be placed on their backs for sleep, avoid bed sharing, use only firm mattresses, no soft bedding in the sleep area, provide a pacifier for sleep, and do not put infants to sleep in a car seat, infant carrier, or swing. Avoidance of secondhand smoke is recommended, and breastfeeding is also recommended. Diagnostic evaluation is through an autopsy. Asthma is a leading cause of acute and chronic illness in children and the most frequent admitting diagnosis in the children's hospitals. Some resources and providers say a young child cannot be diagnosed with asthma at a young age, so instead they call it airway reactive disease until this can be confirmed. Manifestations vary, but can include dry cough, wheezing, shortness of breath, dyspnea on exertion, tachypnea, orthopnea, restlessness, abdominal pain, sitting in the tripod position, fatigue, chest tightness. Diagnostic evaluation includes spirometry for children over 5 years old. If there is an improvement of symptoms in response to nebulized bronchodilators, then asthma is highly likely. A family history of asthma or history of associated allergic manifestations can also help with the diagnosis. GERD and sinusitis needs to be ruled out, but they are also finding now that many times they have those conditions with asthma, so they need to be managed as well. Pulmonary function testing will reveal a decreased forced expiratory volume in 1 second. The peak expiratory flow rate is used to monitor children with chronic asthma. Skin tests can be performed to identify allergens or triggers. For an acute asthma attack, the child needs to be seen by a healthcare provider. Bronchodilators need to be initiated. They will usually start with a short-acting beta-adrenergic agonist known as SABA. An example would be albuterol. Oxygen would be administered as well. Close monitoring and watching for change in the condition will determine the next step in the treatment plan. If the child improves, they may be sent home with instructions of when to return, symptoms to report, and questions answered. They may also go home with a script for corticosteroids if they have not already been part of their treatment plan. If the child does not improve after repeat treatments of the bronchodilators and they have an increase in the respiratory distress, they will be admitted for inpatient care. Once admitted, they will continue with their O2 therapy with humidified oxygen, IV fluids, and access for IV steroids. Chest x-ray will be done, and many times ABGs will be obtained as well. They will continue with the bronchodilator treatments. Some providers will add Atrovent, which is an anticholinergic agent, to the treatment plan. If after all these treatment measures the child is not improved, they will be diagnosed with status asthmaticus. This is considered a medical emergency that can cause respiratory failure or death. The child is on continuous cardiorespiratory monitor and continuous pulse ox, and they are in the ICU. They can increase the doses and frequency of meds, and if no improvement is made, the child may need to be intubated. Long-term management for asthma should decrease and control symptoms to help prevent acute attacks. One thing the family will need to be educated on is for the environmental control. This is done by recognizing and controlling the triggers. Some common triggers include cigarette smoke, smoke from wood-burning stoves, fumes, over-humidified air, and perfumes. Allergy shots sometimes can be beneficial for controlling the specific allergens. Education regarding exercise is also needed as this can be a trigger for asthma. The symptoms will occur about 5 to 10 minutes after starting to exercise. Things that can help to prevent an attack is warming the air by breathing through the nose or covering the mouth and nose with a scarf when exercising in cold weather. Using an inhaled beta-2 adrenergic agonist 30 minutes before exercising can help as well. And practicing techniques to decrease hyperventilation. Children should not avoid exercise. Swimming is a good exercise for asthmatics. Education should be given to try to avoid exposure to people who are sick. Emotional stress can be a trigger as well, so educating and trying to avoid or helping with coping skills. Monitoring for symptoms is to be taught to that child and parent, knowing when to report to the provider. Kids are taught to use the peak flow meter, so using that to determine the extent of the symptoms as well. With the peak flow meter, a baseline is obtained when the child is well, and then that is the point that they use for comparison whenever they're experiencing any symptoms. Medication is a key component to asthma control. You will be completing an assignment for medications, so I'm not going to lecture on those. Bronchopulmonary dysplasia is a chronic obstructive pulmonary disease that occurs as a result of acute lung injury in some infants who have received supplemental oxygen and mechanical ventilation. The manifestations include tachycardia and tachypnea, retractions, and use of accessory muscles. They can be pallor from chronic hypoxia, cyanosis and activity intolerance, which include feeding and handling. They will have weight loss and poor weight gain because it's hard work for them to eat, so they burn off more than they're taking in. Diagnostic evaluation is based on the clinical manifestations and abnormalities on X-ray. It's characterized by its severity. Therapeutic management focuses on prevention. This can be done by providing betamethasone to the mom who's going to deliver that preterm infant to help with that surfactant production, providing surfactant after birth to the preterm infant. The administration of vitamin A may help decrease the need for long-term oxygen. Another preventative measure is to switch the infant to CPAP if tolerated instead of positive pressure ventilation. Other management areas include monitoring oxygen levels and using oxygen if needed. Diuretics and fluid restrictions are used for pulmonary interstitial edema. Monitor electrolytes and correct any imbalances. Bronchodilators may be used. These children have frequent infections and they may become very ill or death can occur. RSV prophylaxis is recommended. High-calorie formula may be initiated to help with the nutritional needs. Nursing care while the infant is in the hospital will be geared towards getting ready for discharge. Education will be needed on signs of respiratory distress, importance of immunizations, importance of compliance with medications, and follow-up care. Many infants will go home with oxygen, so providing education on safety measures. Infection control measures are taught, and evaluation of how the family is coping and making referrals to any community resources that can help them. Cystic fibrosis is a multisystem disorder affecting the exocrine glands. The mucus that is produced by the exocrine glands is abnormally thick and can cause blockages. The glands mainly affected are the bronchioles, the small intestine, pancreatic, and bile ducts. It is incurable. It is considered to be an autosomal recessive trait, which means both parents have to be carriers. This means the parents have a 25% of each pregnancy to be positive for cystic fibrosis. Symptoms can vary depending on the extent of organs involved and the age in which the symptoms appear. Symptoms gradually get worse and eventually will be fatal. Signs that you could see with the respiratory system include wheezing, dry, non-productive cough, repeated episodes of bronchiolitis, pneumonia, and bronchitis, copious amounts of purulent sputum, and chronic bacterial infections. As this disease progresses, crackles, wheezing, diminished lung sounds, use of accessory muscles, hypoxia, and cyanosis. Congestive heart failure can develop. Nasal polyps, sinusitis, digital clubbing, and barrel chest can also appear. Digestive system includes steatorrhea, which is frothy, foul-smelling stools 2 to 3 times bulkier than normal, and flatus. Malnutrition and failure to thrive, vitamin deficiencies. A protruded abdomen, barrel chest, wasted buttocks, and thin extremities are common. Meconium ileus is the earliest sign of cystic fibrosis. Rectal prolapse and intussusception can occur. Liver disease can occur due to the blockages of the bile ducts. Diabetes is also a complication that can occur. Abnormally high concentrations of sodium and chloride in the seats are on and chloride are the early signs of CF. Mother can often report their child tastes salty when kissed. Risk for dehydration and electrolyte imbalance can occur. An average 2-year delay in development or secondary sex characteristics. Females may have a hard time becoming pregnant due to the thick cervical mucus. 95% of all males are sterile due to the lack of sperm. Diagnostic evaluation can happen at birth due to the meconium ileus. Most states will test for CF on the newborn screening test. If both parents are carriers, they can do chorionic villi sampling or amniotic fluid sampling to determine. After birth, they do what's called the sweat test. The sweat test measures the amount of sodium and chloride in sweat and simple and painless. It usually is not reliable in young children younger than 2 weeks due to the fact that it's hard to get a large enough sample to make it accurate. Therapeutic management has to be individualized to each child and is geared towards preventing pulmonary infections. Management of respiratory problems include patent airway by keeping the secretions out. Percussion and postural drainage therapies are done several times a day with inhalation therapy preceding it. Exercise is important for pulmonary care. Regular aerobic exercise can improve or maintain lung function. Antibiotics will be used for infections, but many times they need to be in higher doses due to the body's rapid metabolism of the medications. Steroids are used when other treatment measures are not working. Digestive problems are handled by providing a high-calorie diet to help the child gain or maintain weight. They will be on a high-calorie, high-protein, and they will use pancreatic enzyme replacement therapy. They will be on fat-soluble vitamin supplements, and if nutritional problems are severe, they will be placed on nighttime gastrostomy feedings. The pancreatic enzyme preparation is given with every meal and snack. Histamine 2 receptor blockers or proton pump inhibitors may be given to decrease acidic intestines because the pancreatic enzymes need to be in an alkaline environment. Nursing care is very individualized and helps with each of the therapeutic issues we've talked about. We will educate the parents and be sure that they verbalize understanding of the education. Cystic fibrosis can be a very stressful disease, so support must be given to all family members. Providing information on support groups or counseling should take place.